Welcome to the Certificate Program in Nursing and Nutrition, or CPNN. Today, we will cover the module entitled Feeding of Preterm Infants. On completing this module, participants will be able to recognize the initial feeding method in preterm infants, discuss the indications and recommendations for parenteral nutrition for preterm infants, and understand types of enteral feeds, recommendations, and feed progression for preterm infants. Before we delve into the module, let us get familiar with some of terms that are used in this module. Enteral nutrition refers to the type of nutrition that is provided through a feeding tube. Parenteral nutrition is nutrition that is provided through an intravenous tube called a catheter that is inserted directly into the veins. Necrotizing enterocolitis is the inflammation or death of the gastrointestinal tract. Apnea is the cessation of breathing. Respiratory distress syndrome is the most common lung disease in premature infants, and it occurs because the infant's lungs are not fully developed. Infants with respiratory distress syndrome require extra oxygen and help with breathing. Gut ischemia is a condition in which there is reduced blood flow to the intestine. There are two important events that take place during the last months of pregnancy, particularly the last trimester. One, the fetus gathers and stores nutrients, and two, it undergoes rapid growth and brain development. Infants born prematurely have missed some or all of this crucial period and are therefore deprived of these experiences. Consequently, preterm infants have nutritional requirements that are much higher than those of term infants. Most preterm infants experience extrauterine growth restriction and are also at risk for developmental delays. Therefore, providing optimal nutrition for the premature infants is a crucial task. It has a significant impact on future growth and brain development. Preterm infants often have problems that impact their nutritional status. They have increased metabolic demands from illness severity and respiratory distress, which affects their ability to absorb and use nutrients. Further, this altered metabolism often results in hypoglycemia, hyperglycemia, hypocalcemia, and metabolic acidosis. Renal issues in preterm infants lead to fluid and electrolyte imbalances. In terms of their gastrointestinal system, preterm infants often have decreased gut motility, necrotizing enterocolitis, and poor tolerance of enteral feeding from medication exposure and underdeveloped gut lining. Moreover, preterm infants demonstrate inadequate feeding capabilities. They have immature oral reflexes, reduced sucking effort, small number of sucks, no coordination between sucking, swallowing, and breathing, risk of choking, and difficulty accepting full volumes by the oral route. What is the goal of nutrition for preterm infants? According to the American Academy of Pediatrics, it is to provide nutrients to approximate the rate of growth and composition of weight gain for a normal fetus of the same postmenstrual age and to maintain normal concentrations of blood and tissue nutrients. Enteral feeding should be started as soon as possible after birth, using mother's colostrum and breast milk as first choices. Parenteral feeding is indicated in infants who cannot tolerate enteral feedings and/or when normal metabolic needs are not met by normal enteral feeding. We will discuss further details during this session. Enhanced nutrition of preterm infants, both intravenous and enteral, beginning right after birth, promotes positive energy and protein balance and improves longer-term neurodevelopmental outcomes. Furthermore, the benefits are long-lasting, especially in the prevention of chronic diseases in later life. On the other hand, preterm infants who fail to receive the necessary amounts of all the essential nutrients not only experience growth failure, but also increased morbidity and less than optimal brain development. Moreover, poor nutrition in a preterm infant is linked to poor head growth, persistent smaller head size, which in turn causes impaired psychomotor and mental skills, higher rates of cerebral palsy, and autism. Impaired weight and growth in preterm infants are significantly associated with adverse neurodevelopmental outcomes in later life. One of the main reasons for poor nutrition is delayed initiation of nutrition. Enteral feeding may be delayed due to abdominal distension, gastroesophageal reflux, hyperglycemia and/or rebound hypoglycemia, low saturation of peripheral oxygen, or if the preterm infant was on a ventilator or continuous positive airway pressure. Abdominal distension may indicate necrotizing enterocolitis. Gastroesophageal reflux may lead to apnea. Hyperglycemia and/or rebound hypoglycemia is an indication of poor metabolism and infections. Low saturation of peripheral oxygen may result in slow metabolism of nutrients. Nutrition is delayed if the preterm infant was on continuous positive airway pressure for the fear of air entering the stomach and fear of slow digestion and absorption if on a ventilator. Parenteral nutrition can be delayed due to the following reasons: gut ischemia, or necrotizing enterocolitis, preventing the use of umbilical vein or umbilical artery catheters. High blood urea nitrogen, which may be indicative of urea and amino acid toxicity. Hypo or hyperkalemia, which may interfere with gut function. Let us now understand the various aspects of parenteral nutrition for preterm infants. Preterm infants often experience feeding intolerance due to gastric dysmotility, poor motility of the intestine, and presence of other complicating illness. Also, as discussed before, preterm infants have inadequate feeding capabilities. Consequently, the advancement of enteral feed is slow, and full enteral feeds are often delayed. For instance, it may take at least 5 to 10 days to reach full feeding in a preterm infant of more than 29 weeks gestation. Thus, parenteral nutrition is crucial in supplementing enteral feeds and thereby ensuring that total daily intake meets the preterm infant's nutritional needs. However, parenteral nutrition should not be a long-term substitute for enteral feeding. Parenteral feeding, including amino acids, should be started right after birth at rates that are appropriate for the gestational age of the infant. The table on screen displays the parenteral fluid intake for preterm infants recommended by the American Academy of Pediatrics and the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. The American Academy of Pediatrics recommends 140 to 180 milliliters per kilogram per day and 120 to 160 milliliters per kilogram per day fluids for preterm infants weighing less than 1,000 gram and 1,000 gram to 1,500 gram respectively. The European Society of Pediatric Gastroenterology, Hepatology, and Nutrition recommends gradually increasing the fluids from day 1 to day 6, with amounts varying based on the birth weight. During the next phase, 140 to 160 milliliter fluid per kilogram per day is recommended, irrespective of their birth weight. The parenteral macronutrient intake recommended for preterm infants has been displayed on the screen. Both recommendations are similar. However, the American Academy of Pediatrics recommendations vary based on the birth weight, and the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition recommendations for protein and carbohydrate begin with lower quantities and gradually increase over the next few days. The recommended parenteral vitamin intake for preterm infants has been displayed on the screen. Both recommendations suggest the same amounts of vitamin A, E, K, and C. The difference lies in vitamin D and thiamine, wherein the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition recommends higher than the American Academy of Pediatrics. Both the American Academy of Pediatrics and the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition suggest the same amounts of other B-complex vitamins. The recommended parenteral mineral and electrolyte intake for preterm infants on the screen shows that while the recommendations for iron, zinc, and iodine are similar, electrolyte and calcium recommendations vary. The transition from parenteral nutrition to complete enteral feeding is important due to nutrient gaps that arise when parenteral nutrition is tapered and enteral intake is insufficient. Consequently, nutritional needs are not met. This is especially true in the case of protein. Thus, parenteral amino acids should not be tapered before enteral nutrition intake of at least 75 milliliters per kilogram has been achieved. In general, parenteral nutrition for preterm infants can be discontinued when a minimum of 120 milliliter per day enteral feed intake has been achieved. Now that we have reviewed parenteral nutrition, let us discuss the various aspects of enteral nutrition for preterm infants. Parenteral nutrition alone can complicate enteral feeding, as it can lead to reduced gastrointestinal villus development, which is required for absorption of nutrients. Moreover, parenteral nutrition decreases the secretion of digestive enzymes, decreases gut motility, and reduces secretion of incretins, which are important for insulin secretion. Enteral feeding promotes gastrointestinal development even when given in small amounts. Enteral feeding is beneficial for several reasons. It improves the capacity for feeding tolerance and growth, decreases the need for phototherapy by promoting stooling, reduces cholestasis, which is the reduction or stoppage of bile flow, decreases osteopenia, a condition of weak bones, enhances gastrointestinal motility, and promotes gastrointestinal hormone secretion. Remember, Gastrointestinal mucosal growth and development depend on enteral, not parenteral nutrients. Delivery route options for enteral nutrition include orogastric, nasogastric, or through a gastrostomy tube, and gastric versus transpyloric. However, it is recommended that enteral feeds are given through the gastric route and less commonly by transpyloric route. Enteral feeding should be started as soon as possible after birth, using mother's colostrum and milk as first choices. Delays in feeding introduction may result in longer periods before achieving full enteral feedings and delays in hospital discharge. There is no consensus on the best approach to provide enteral feeding to a preterm infant. However, there are basic principles. Enteral feeding should begin with trophic amounts of 20 to 30 milliliter per kilogram on day 1 and advanced as rapidly as tolerated, decreasing parenteral nutrition accordingly while maintaining nutrient intakes at recommended rates. Minimal enteral nutrition, or trophic feedings, or gut priming are small feedings that are thought to promote gastrointestinal maturation, reduce mucosal atrophy, and protect against necrotizing enterocolitis. Therefore, trophic feedings should be started as soon as possible. After initiating enteral feeds with trophic amounts on day 1, advancement of feedings by increments of 20 to 30 milliliter per kilogram per day is reasonable for preterm infants with birth weight between 1,000 gram and 1,500 gram. For preterm infants weighing less than 1,000 gram, lower volume advancement is generally used. However, slower rates of advancement of less than 24 milliliter per kilogram per day have not been shown to reduce the risk of necrotizing enterocolitis in very low birth weight infants. Faster advancement of up to 35 milliliter per kilogram per day shortens the time to achieve full feedings and regain birth weight without increasing the risk of necrotizing enterocolitis. Enteral feeds can be provided in 2 ways: continuous feeding or intermittent bolus feeding. Continuous feeding is defined as delivering enteral nutrition with a constant speed for 24 hours through a nutritional pump. In infants weighing less than 1,250 gram, continuous feedings may improve weight gain and lead to earlier discharge. Further, in very low birth weight infants, continuous feeding helps to decrease energy expenditure, improve gastrointestinal maturation, reduce reflux, and improve feeding tolerance. Intermittent bolus feeding is defined as delivering enteral nutrition multiple times, generally given for 15 to 30 minutes every 2 to 3 hours by gravity or electric pump. Feeding every 2 hours improves feeding tolerance and therefore reduces the time to achieve full volume. For some infants, especially those with feeding intolerance, slow bolus feedings for 30 to 120 minutes may be better. The choice of enteral nutrition is as follows: mother's own milk, which is the primary nutritional source for preterm infants; donor human milk, which is good option for initiating enteral feeding in the absence of maternal breast milk; and preterm breast milk alternatives. These are breast milk alternatives which are specifically designed for preterm infants and is appropriate to use if mother's own milk or donor human milk is not available. We will discuss more about these in the subsequent modules. In summary, providing optimal nutrition for the premature infants is a crucial task, and it bears a significant impact on the future growth and neurodevelopment of these infants. Nourishing preterm infants involves both parenteral and enteral nutrition, beginning right after birth. The American Academy of Pediatrics and the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition have recommended similar parenteral and enteral nutrient intakes for preterm infants. Enteral feedings promote gastrointestinal development, even when given in small, trophic amounts. Enteral feeds can be provided either by continuous feeding or intermittent bolus feeding, and the gastric route is preferred. Mother's own milk, pasteurized donor human milk, and preterm breast milk alternatives are the different choices of enteral feeds.